Hi, I'm Dr. David and I'm the director of ACE-USMLE and I will be taking your sessions on behalf of ACE-USMLE team. This is just a trial session so that you have an idea about the way of teaching. So let's discuss about coronary artery disease. Okay, so as the name suggests, it's a disease of the coronary blood vessels, as you can see. So this is a normal coronary artery and the patient is young, like 25 or 30-year-old patient without any risk factors. Okay, and this is the patient with atherosclerosis. This is the patient with coronary artery disease. So the patient has these risk factors like high blood pressure or smoking, or the patient is older, or the patient has a, first degree relative with coronary artery, premature coronary artery disease, less than 55 years in case of males and less than 65 years in case of females, or coronary artery disease equivalent risk factors, okay, like diabetes or peripheral artery disease or carotid artery disease. Okay, so these will be discussed later. So, because of any of these risk factors, patient has one or two or many or three or four, whatever. Okay, these risk factors are present. So that will lead to formation of an atheromatous plaque in the blood vessel. So when there is formation of this plaque, it will cause reduced blood supply to the concerned organ. In this case, it is the heart because it's a disease of the coronary blood vessels. Okay. Now, whenever the patient exerts himself, or whenever he is under stress, or whenever the patient exerts himself, that will lead to typical anginal chest pain. Okay, so there are three characteristics of typical anginal chest pain, like it is substernal chest pain or discomfort, it gets aggravated on exertion, and the third is get relieved with rest or nitrates. Okay, so these are the three typical characteristics of chest pain. So this will occur when the patient has this kind of blockage in the coronary blood vessels and when the patient is under stress. Okay, so like we are somewhere here. So this is the blood vessel with a blockage. Okay, and so this is the blockage. Okay, and patient will, so this is a and the patient will say that I have chest pain whenever I exert myself, and it gets relieved when I take nitrates or when I take rest. Okay, so this is called chronic stable angina. This is a this is the typical characteristics of chronic stable angina. Okay, now sometimes what happens, the patient, like there is rupture of the plaque and that will lead to formation of a clot because there is activation of the platelets, and this activation of the platelets will cause partial blockage or full blockage. Okay, so there is rupture of the plaque and this will cause formation of a clot, and that will cause partial or complete blockage. Okay, now if there is complete blockage, it will lead to transmural infarction, or also called ST segmental lesion MI. I will explain. And if there is partial blockage, it will lead to unstable angina or subendocardial infarction. Okay, or non-ST segmental elevation MI, non-STEMI. Okay, so like we are here, and this plaque now rupture and there is formation of a clot, and this clot will lead to blockage of the blood flow. Okay, and depending upon the blockage, either it is partial blockage or complete blockage, so the patient will have unstable angina or non-STEMI or ST segmental elevation MI. Okay, so this unstable angina or non-STEMI or ST segmental elevation MI, so this is called acute coronary syndrome. Earlier there was just a fixed blockage like this, like in this case there was just a fixed blockage. Okay, so the patient, that was chronic stable angina. Now the plaque ruptured and there is partial or complete blockage, and the patient is having acute coronary syndrome, and it includes three things. We have either, so because of partial blockage we have unstable angina or non-ST segment elevation MI, and because of full blockage there is ST segment elevation MI. Okay, so these three things include, come under acute coronary syndrome. Okay, okay, now this is what's happening. Now when there is partial blockage, it can either lead to subendocardial ischemia or subendocardial infarction. Okay, and if there is complete blockage, it will lead to transmural infarction. Okay, now if there is subendocardial ischemia, it leads to unstable angina. So on EKG we will see ST segment depression. Okay, this kind of ST segment depression, like this. So this is ST segment depression. Okay, The EKGs I will be taking up later in details. So whenever you look at the EKG, you have to look at the baseline. So this is the baseline. So this is the P wave, the QRS. Okay, so the waves returned to the normal baseline, and here it is ST segment depression. As you can see, this is the normal baseline, and there is depression of the ST segment. Okay, and this is ST segment elevation. So this is the normal baseline. Okay, and there is elevation of the ST segment. Okay, and here it is T wave inversion. Okay, so always look at the baseline. Okay, so this while looking at the baseline, you can know whether it is ST segment elevation or depression or PR segment elevation or depression, whatever. Okay, depending upon the condition. Okay, so here the patient has ST segment depression. Now that means the patient, there is partial blockage. That means there is partial blockage, and that causes subendocardial ischemia or subendocardial infarction. Okay, so that means the patient has either unstable angina, or non-STEMI. Okay, so depending upon the whether the enzymes are raised or not. Okay, now the patient comes to you, like suppose he's your patient from the last so many months, and he has typical characteristics of chronic stable angina. Like the patient is somewhere here, he has typical characteristics of chronic stable angina. Okay, so you are prescribing him the patient nitrates, and you are asking, okay, to control your blood sugar and avoid fatty food, whatever. Okay, now one day the patient comes to you and in the emergency room with acute chest pain, very severe chest pain. The patient is sweating and all others, nausea, vomiting, or maybe there is loss of consciousness. So what is happening? Earlier there was a stable plaque. Okay, now there is a rupture of the plaque and there is partial or complete blockage. Okay, so the patient comes to you with these symptoms in the ER with sweating, nausea, vomiting, or loss of consciousness, or there is a severe chest pain. Okay, and there is severe chest pain. Okay, so you do EKG, and on EKG you will find this kind of picture: ST segment depression. ST segment depression. Okay, you find this kind of picture, ST segment depression. Okay, so that means the patient has either unstable angina or non-STEMI. Okay, so either unstable angina or non-STEMI. Okay, so you don't know what the patient has, and so it depends upon. So unstable angina is subendocardial ischemia, and non-STEMI is subendocardial infarction. Okay, so the difference between the two is that, okay, on EKG we will see the same thing. There is ST segment depression. Okay, this kind of ST segment depression. Okay, but when we order the enzymes like troponin T or CPK-MB, generally troponin T is the most sensitive, or CPK-MB, LDH1 and LDH2, these are not important. Generally we do go for troponin T. So these enzymes will be raised. Why? Because there has been damage to the heart muscle. Okay, so when there is damage to the heart muscle, there is infarction. That means there is dead tissue. Okay, so that will cause liberation of the enzymes, and the enzymes will be raised. Okay, so the patient came with acute chest pain, and he's your patient from the last so many months, and now he has severe chest pain, and you do EKG, and EKG shows ST segment depression. So you don't know what is happening. It is either subendocardial ischemia or subendocardial infarction. Okay, so you order enzymes. If the enzymes are raised, then it is subendocardial infarction, that is non-ST segment elevation MI. And if the enzymes are normal, then it is a case of subendocardial ischemia, that means unstable angina. Okay, so this is the scenario. We saw this kind of picture, ST segment depression, and the patient has either infarction or ischemia, depending upon whether the enzymes are raised or not. Okay, so we are somewhat here. Okay, there is partial blockage. Okay, and this may embolize. Okay, and there is either can be subendocardial ischemia or infarction, that is a non-STEMI, non-ST segment elevation MI, or unstable angina. Okay, now suppose there is a rupture of the plaque and there is formation of a clot and there is complete blockage of the blood vessel. Okay, so this can lead to ST segment elevation MI. So the patient is, he's your patient for the last so many months with chronic stable angina. One day he comes to you in the ER and he's sweating, he has loss of consciousness, nausea, vomiting, or whatever, and a severe chest pain, and you do EKG, and on EKG you find ST segment elevation. you find ST segment elevation, that means the patient has transmural infarction. So the patient has transmural infarction. ST segment elevation, that means the patient has transmural infarction throughout the wall of the uh, um, uh, throughout the means the complete portion of the ventricle wall is involved. Okay, so that is transmural infarction. Okay, and your order enzymes mainly troponin T, and these will be raised. So this is ST segment elevation MI, and the patient has, that means transmural infarction. Okay, so the treatment in these cases, well, the treatment portion I will discuss later. Means the treatment depends upon the symptoms. Generally, in case of unstable angina, this portion, unstable angina, non-STEMI, we generally give the patient MONA, that is morphine, oxygen nitrate, and aspirin, and also HSBC, that is heparin, statins, beta blockers, and clopidogrel. So these are means the details I will take up later. And so the treatment of unstable angina and non-STEMI, it is the same. Okay, and the protocol is the same, but you have to diagnose whether the patient is having a subendocardial ischemia or infarction. Okay, that is a unstable angina or non-ST segment elevation MI. Okay, and if the patient is high risk, then we can go for GP2B3 inhibitors or early angiography, like the patient has multiple attacks in the past few weeks, or the patient is more than 65 years of age. That is a TIMI score that I will cover later. Okay, so when these things are present, then we will go for a means GP2B3 inhibitor. Then we give the patient GP2B3 inhibitors, or we give the patient, and also we go for early angiography. So the details of the treatment I will cover later. Okay. So for now, being this is the scenario. Okay, chronic stable angina, three characteristics of chest pain, and we prescribe the patient with various drugs. And one day the patient comes to you with acute chest pain, and the patient will have, we will have these symptoms. So either non-STEMI or STEMI. ST segment elevation MI means transmural infarction, and non-ST segment elevation MI means subendocardial ischemia or infarction. Okay. Now we come to the same situation like this. Okay. So the patient has atheromatous plaque. Patient has risk factors, and he has formation of this atheromatous plaque, and this plaque causes symptoms depending upon the condition. Okay. Depending upon the organ involved. Now, suppose the patient has these risk factors like hypertension, smoking, and diabetes mellitus, and there can be formation of a plaque in other condition, other blood vessels also, like peripheral blood vessels or carotid arteries, or in case of mesenteric blood vessels. Okay, like the patient has these risk factors: hypertension, smoking, and diabetes mellitus. Okay, so the patient has this plaque in mesenteric blood vessels. Suppose the mesenteric blood vessels are the blood vessels which supply the GI. Okay, now whenever there is a so the patient will, so now this plaque occurs in the mesenteric blood vessels. Okay, now the patient will say that uh, whenever I take heavy food, I have pain in my belly, and the pain gets relieved after some time, and so the patient will develop aversion to food, and he will have weight loss. So what is happening? So the same pathophysiology is the same. The patient has plaque in the mesenteric blood vessels now. Okay, but the symptoms are different because the organ involved is different, because the blood vessels are different. Now there are mesenteric blood vessels which are supplying the GI. Okay, so this is called chronic mesenteric angina. Okay, so the patient says that whenever I take heavy food, I have pain in my belly, and it gets relieved after some time. So this is the plaque in the mesenteric blood vessels. Okay, so the scenario is the same, like this thing. Okay, plaque formation. Okay, but so earlier it was chronic stable angina because it was coronary artery disease. Now it is the mesenteric blood vessels. Now it is chronic mesenteric angina. Okay, now suppose this plaque ruptures. Now this plaque ruptures, and there is formation of a clot, and this clot will lead to acute blockage. Now suppose this thing occurs in the mesenteric blood vessels, so the patient will have like earlier, like the patient has chronic mesenteric angina. Now the patient will have acute ischemic colitis, like the blood vessels will supply the large intestine. those are blocked. Okay, so that will lead to acute ischemic colitis. So the patient will have acute abdominal pain and bloody diarrhea. So bloody diarrhea occurs in case of acute ischemic colitis. So earlier what we had was in case of coronary blood vessels, we had unstable angina or non-STEMI or STEMI depending upon the condition. Okay, now we have acute ischemic colitis because of the rupture of the plaque, and there is formation of a clot causing acute blockage. Okay, and suppose so this blockage is occurring in the blood vessels which are supplying the large intestine. So that's why the patient has acute ischemic colitis with abdominal pain and bloody diarrhea. Okay, now suppose this rupture of the plaque occurs in case of this rupture of the plaque and formation of a clot occurs in case of the blood vessels which are supplying the small intestine. So in that case, the patient will have acute mesenteric ischemia or acute mesenteric angina, whatever. So in that case, we will have a severe abdominal pain and also tenderness. Okay, so when the blood vessels were to the large intestine, then we had acute ischemic colitis causing bloody diarrhea and abdominal pain. And if the blood vessels are which are involved is the blood vessels which are supplying the small intestine, then the patient will have acute mesenteric angina, like the patient will have severe pain and tenderness without bloody diarrhea. Okay, so now there is involvement of the small intestine. In acute ischemic colitis, it was the large intestine. Okay, so as I say, so I'm repeating again. So the pathophysiology is the same. Okay, formation of a clot, formation of plaque, that is chronic stable angina, chronic mesenteric angina. Okay, and in case of peripheral blood vessels, it is claudication. Okay, and when there is rupture of the plaque, there is formation of a clot, so the patient will have non-STEMI, unstable angina, or STEMI. And in the mesenteric blood vessels, it is acute ischemic colitis or acute mesenteric ischemia. Okay, and if the same thing occurs in the peripheral blood vessel, then there is acute arterial occlusion, like the 5 P's which occur. Okay, pallor, paresthesia, paralysis. Okay, now so as you can see, the pathophysiology is the same, but the symptoms are different according to the organ involved. Okay, now again we come to chronic stable angina. Like the patient is somewhat here. He has a typical characteristics of three typical characteristics of chest pain, and he comes to you in your office. Okay, doctor, whenever I have this substernal chest pain, and whenever I exert myself, I have this pain gets aggravated, and whenever I get rest, the pain gets relieved. Okay, so you suspect coronary artery disease. It can be other thing also. It can be GERD, the pain of GERD, gastroesophageal reflux disease, or the pain of angina. They means it's sometimes it's very difficult to differentiate between the two clinically. So you don't know what is happening. You suspect coronary artery disease. So the first thing you will do is you will go for EKG. Okay, and suppose EKG is normal. Suppose suppose you did EKG and EKG suppose is normal. Okay, so you suspect coronary artery disease, but the EKG is normal. Okay, still the patient has risk factors like hypertension or smoking. So what you will do is you will make the patient you will make the patient run, that is on a treadmill. You ask the patient, okay, you come tomorrow or maybe whatever according to your convenience, and I will make you run with the electrodes on your chest, and I will connect those electrodes to the EKG, and we will record your EKG. Okay, so the patient comes after a few days, and we will go for this stress test. So we are doing this stress test. Why? Because we suspect coronary artery disease, but the patient resting EKG, it is normal. Okay, because the patient does not have any chest pain now. Okay, so we'll make the patient heart under stress. We will put the patient under stress so that there is ischemia, so that there is a as there is plaque, there is ischemia, so that will lead to chest pain. Okay, if the stress test is positive. Now suppose the patient says I cannot run, the patient is obese, or the patient says I cannot run, or the patient has severe osteoarthritis, whatever the condition is, the patient cannot run. So in that case we will go for pharmacological stress test. Okay, so the patient has chronic stable angina, means we suspect chronic stable angina. The patient comes to us with chest pain, with three typical characteristics of chest pain. We do EKG is normal. So we put the patient, okay, we say, okay, we will do the TMT test, that is the EKG stress test, and the patient says I cannot do because I have severe osteoarthritis, or the patient is very obese. So in that case we'll go for pharmacological stress test. Okay, so what is pharmacological stress test? So as the patient cannot run, we give the patient few drugs like dobutamine or dipridamole or adenosine. Okay, so adenosine or percentine or dipridamole or dopamine. Okay, so these drugs will cause the same effect as when the patient runs. Like when the patient runs, there is tachycardia, so these drugs will also have the almost the same effect. So this is called pharmacological stress test, and we are doing this because the patient has the patient cannot run, he cannot go for stress EKGs, so we'll go for pharmacological stress test. So suppose we give the patient dipridamole or percentine. Okay, so these drugs, dipridamole or also called percentine or adenosine, they cause dilatation of the blood vessel. So as you can see, this is the normal coronary artery, and this is the formation of plaque. And so whenever there is plaque formation, that will lead to dilatation of the blood vessels. Okay, so fully dilated arterioles. Okay, so these are the arterioles. So this is the normal arterial tone, and these are the arterioles which are dilated. Okay, so as you can see, there is dilatation of the blood vessels. Okay, means the blood vessels which are blocked, they are dilated. Okay, so these drugs, suppose like we are conducting a pharmacological stress test and we are giving the patient dipridamole. Okay, now these drugs causes dilatation of the blood vessels. Okay, now what happens, the blood vessel which is blocked, there is blockage here. Okay, so it is already maximally dilated. Okay, so the blood flow will flow to the in the collaterals. Okay, and so this artery is blocked, it is already maximally dilated, as you can see. And so the blood will flow in the areas which have normal blood supply, in which there is no blockage. Okay, through the uh, through the collaterals, and this is called coronary steal phenomena. This is called coronary steal phenomena. So these drugs cause dilatation of the blood vessels, as the blood vessels which are blocked, they are already maximally dilated, so the blood will flow in the areas where there is normal blood flow. So do compare this thing, blood flow to normal myocardium and blood flow to normal myocardium, it is increased. Okay, because of coronary steal phenomenon, because we are giving these drugs. Okay, now okay, so this thing is happening. So we gave the patient cannot run, and we do pharmacological stress test, we give the patient dipridamole. Okay, and there is this is coronary steal phenomena which occurs. Now when we do pharmacological stress test, we give the patient these drugs, and also we give the patient another drug which will be taken up by the myocardium. It is either thallium or technetium. Okay, so like the thallium or technetium we are giving the patient, and so we give the patient dipridamole, and also we give the patient thallium or technetium. So that so as the patient is under stress because of because he is taking these drugs. Okay, so that will lead to tachycardia, that will lead to increased heart rate, that will put the patient's heart under stress. Now because patient's heart will be under stress, so and when we inject when we inject technetium or thallium, as we give, as I said, we give two drugs, either percentine, one is percentine or dipridamole, and also the technetium or thallium. So the the area of the myocardium which has normal blood flow, it will take up thallium, because thallium will get distributed in the areas, as you can see from this picture. The thallium will be distributed in the areas which have normal blood flow. Okay, and this is the area of ischemia. This is the area of ischemia. Okay, so thallium will not be taken up by the area of the myocardium which has reduced blood flow. Okay, so this area will not be taking up the thallium. Okay, and so this area, it is actually this one, which has reduced blood flow. Okay, so thallium will not be taken up by by the area which has normal blood flow. Okay, sorry, it will not be taken up by the area which has blockage. Okay, so we will see this kind of picture when we go for pharmacological stress test. Okay, so that supports our doubt. The patient had chronic stable angina. He came to us and with chest pain, means now there is no chest pain. We did EKG. EKG is normal, so we suspected coronary artery disease. We asked the patient, okay, let's do TMT. The patient said, I cannot run because I have severe osteoarthritis. So we did pharmacological stress test. We we gave the patient percentine or diapridamole, that is putting the patient under stress. And when we give this kind of drug, we also give the patient thallium or technetium, which will be taken up by the normal tissue only. So this tissue, it is this one. It is this tissue, okay, which takes up normal thallium or technetium, okay. So we'll see this area. So this will be taken up. This picture will be taken up by special X-rays, okay, and so the patient will have reduced blood flow, okay, and there is no thallium here, okay. I think I've made it clear. So this is the bluish zone. The blue zone, that means under stress, okay. And this thing will occur under rest, okay. So suppose the patient is resting, we are not giving the patient any diapridamole or adenosine or dobutamine, okay. So patient is resting, okay. So in that case, if we inject thallium, okay, so the patient will have, there will be complete blood flow. There will be complete blood flow, okay. So we will have no area of ischemia, okay. But when we put the patient under stress by giving the patient some drugs, so that will lead to a zone of ischemia. So this area will not be taking up any thallium because there is blockage, that is, there is reduced blood flow. So that supports our doubt that the patient has in fact chronic, the patient in fact has coronary artery disease, okay. So once this thing is done, okay, this supports our our doubt that the patient has in fact coronary artery disease. So now we know that the patient has coronary artery disease, but we do not know that the patient has means in which area we have blockage, okay. So in that case, we'll go for angiography. I will discuss the details later, okay. So this is just that, as I said, this was just the trial session. So you can log on to our website, that is ACE-USMLE.com, and you can come to our Facebook page. Also, there are a lot of questions, and you will see a lot of videos. Also, you can have a look on those videos and also solve those questions. And you can contact us for if you want to take sessions. Okay. So thank you very much. Bye bye.